On the first half, we are dealing with pattern recognition on the anterior complex, and then we'll have a live demo where we try to explore anatomical landmarks on fetal brain evaluation. We'll start with some basic from the anatomy. The cavum septum lucidum is a fluid-filled cavity. We really don't know the origin of this fluid because it's not connected with the ventricular system nor with the subarachnoideal system. It is rectangular or triangular. 1 out of 4 will be triangular. It's closely related with the leaflets of the septum, with the anterior horns of the lateral ventricles, with the corpus callosum, the genou, the knee, and also with the interhemispheric fissure. It's easy to identify it in axial evaluation, but also in coronal evaluation. Here in blue, we are able to visualize the septi that are 2 thin vertical membranes that run from the corpus callosum until the fornix, and between them we have the cavum that is in close relation with the corpus callosum. The fornix here is placed more or less on the same level of the thalacroidea, and something with the third ventricle. It's very interesting to note this. This is the interthalamic adhesion that is one important landmark on the morphology of the third ventricle. We are also able to identify here the optic chiasma and the Sylvian fissure. Is an important landmark on screening, and it's very important that we make all the image, including the CSP. The screening axial image must include the CSP. The CSP is visible between 18 and 37 weeks. Later in gestation, it can fuse. It's almost always fused after 3 months of birth. There is a wide variation on the width, but we can take about 6 millimeters as the upper limit on the range of the morphologic scan, 20 to 23 weeks. There is a common pitfall that is mistaken the columns of fornix for the CSP, but the columns of fornix are 2 hypoechoic lines without fluid inside and that don't interrupt the interhemispheric fissure. In reality, they are a little bit below the level of the cavum septum lucidum. Here, the columns and the cavum. I try to divide this situation, alteration of the anterior complex in 2 big groups. The first one, we are not able to visualize the CSP. And in the second one, the CSP is present, but the morphology is abnormal. For the first one, we start with the absent CSP and wide separation of the anterior horns. In this case, we are not able to identify the CSP, and we have a wide interhemispheric fissure. That, in the association of a colpocephalic lateral ventricles and the wide separation of the anterior ventricles, gives the teardrop aspect of the ventricle. That is very suggestive of complete agenesis of the corpus callosum. However, the diagnosis relies on the identification of its absence on sagittal and coronal planes. On sagittal planes, we are not able to identify the cavum nor the corpus callosum. And in coronal planes, we can see that the interhemispheric fissure runs down to the third ventricle without any kind of interruption. We can use Doppler interrogation, but it's not really important for this diagnosis. In the complete agenesis, the anterior cerebral artery fails to form the loop to the pericallosal artery. It's more interesting to see that here are the veins, the interocerebral veins, and the vein of Galeno, because we are using in this SMI, that is a low-velocity Doppler. Also, on the late term of the gestation, we have this typical pattern of dislocation that goes from the roof of the third ventricle radiating to the exterior. It's very typical of complete agenesis of the corpus callosum, and that don't change the diagnosis, the prognosis of the situation. But agenesis of the corpus callosum, complete or incomplete, are associated with malformations of cortex development. And these three babies, we can see that they have premature sulci, both in the internal aspect of the cortex, in the superior aspect of the cortex, and the posterior aspect of the cortex. And that is associated with poor prognosis. But bear in mind that the key for the screening is the pattern recognition on the axial plane. There is another common pitfall. Sometimes the roof of the third ventricle in complete agenesis of the corpus callosum are slightly upper displaced, and that can mimic the CSP and give us a wrong diagnosis. Another group, we don't have CSP and have anterior fused horns. Like in this case, in coronal evaluation, we are not able to see the leaflets of the CSP. If we have otherwise a complete normal evaluation, this could be a genesis of the septum lucidum. And that situation is most frequently with a good prognosis. But we must discuss also differential diagnoses like septo-aortic dysplasia. It's not too frequently. Septo-aortic dysplasia plus malformations of cortical development, lobar holoprosencephaly, or disruption of the septum lucidum. We can identify the optic chiasma on ultrasound, on prenatal ultrasound. For me, the easiest way was described by Vinales is on the coronal approach. We take the anterior cerebral artery as landmark, and the optic chiasma is between these yellow arrows. But bear in mind that a presence of a normal optic chiasma in prenatal evaluation in ultrasound or in MRI don't exclude completely septo-aortic dysplasia. So it's still a difficult counseling these couples. Another situation for differential diagnosis of fused anterior horns is lower or low prosencephaly. But in this situation, we have not a normal corpus callosum and an incomplete interhemispheric fissure. On the right, we have a typical sign that is the cerebral artery runs under the skull, and that is because the interhemispheric fissure is incomplete on the anterior portion. Now you come to the last of this group, that we are not able to identify the cavum septum lucidum because it is obliterated. Here we are able to identify the two leaflets, the two septi, but no fluid inside it. And also in sagittal evaluation. Sometimes the cavum verga is patent. Absence of fluid in the cavum septum lucidum, if isolated, if everything is normal, is probably a benign situation, as described by Mellinger in 2012. Now we change topics. The CSP is present, but is abnormal in shape. The first situation, the CSP is squarish, shorter and wider. We can have a subjective evaluation of that, is shorter, wider, sometimes rounded, or we can use the ratio described by Shawi, that is length over width ratio. It's probably the same. It's very frequently associated with partial agenesis of the corpus callosum. Most of the situations have a ratio under 1.5, but if you look to the data, most of them have a ratio around 1 that should be really squarish. Another situation is a dilated CSP described the width over 95 percentile. That is associated with an euploid fetus. But bear in mind that we don't know how this marker will interact with the other soft markers that we already know, and we don't know what is important after the first trimester screening. It's also associated with deletion 22q. And this is a hint, probably, if you have any cardiopathy, conotroncal cardiopathy, or hypoplastic thymus, and this situation. I don't know really if it's isolated, so if we should valorize it. The last situation is a distorsus anterior complex. It also can range a lot. In this situation, we have a really distortion, and the midline is really distorted. There is some heterogeneity here, and we have a rounded anterior horn of the ventricle. That is very suggestive of malformation of the cortical development, and in this case was meningocephaly and polymicrogyria. But on the other hand, we can have more subtle distortion of the anterior complex, and if everything is normal, that situation is also normal. So, in summary, we can divide this pathology into groups. The first one, we are not able to identify the septum lucidum. If the anterior horns are quite apart, is very suggestive of complete agenesis of the corpus callosum. If we have fused horns, we can have agenesis of the septum lucidum, but we also must discuss septo-aortic dysplasia with malformation of cortical development, lobar holoprosencephaly. If we have obliterated cavum septum lucidum, if everything is normal, it will be probably a normal variant. And if we are able to identify the septum, the cavum septum, but is abnormal in shape, a squarish or a rounded CSP, is the risk to have partial agenesis of corpus callosum is very high. If we have dilated CSP, we may think about trisomy or deletion of 22q. If we have distorted CSP, we must really perform a complete examination to rule out malformations of cortical development. Thank you, Isolde. I think now we are going to... Well, we will start. I like to imagine that every time we are performing a brain evaluation, we have to be as strict as a nuchal scan. So sometimes we have images like this, which are too small with the focus that is not in place. So the first advice is try to get good image, good magnification, and the focus well in place. Try to get an overview of the baby. He's on bridge position. A quick overview of the brain. So let's start. We start with strict axial planes in order to be able to get accurate measurement. And we'll be using the anterior landmark, the CSP, anterior horns or lateral ventricles, corpus callosum, thalamus, third ventricle, ambient cistern. We should also take a look on the Sylvian fissure. This lady has 23 weeks. This angle, as described by Edwin Querello, at 24 weeks should be 90 degrees, is almost there. The landmark for this evaluation is the fornix anteriorly and the ambient cistern posteriorly. For the measurement of the lateral ventricles, we use as a marker the periato-occipital fissure. You take the inner aspect of it and take the measurement without including the walls. To evaluate, for evaluation of the posterior fossa, we also use as anterior landmark the cavum and rotate slightly posteriorly. And here we are able to identify the vermis and the fourth ventricle. That should be shorter and wider, as Laurent Guivaud described it. Now we are going to the sagittal evaluation. I'm really on the top of the uterus. It's not an ideal position. Mm-hmm. Mm-hmm. Here we are able to see the rostrum of the corpus callosum, the tela choroidea. From this point, if you turn 90 degrees the probe, we'll obtain the coronal evaluation, and we go up and down. We turn 90 degrees, we return to sagittal evaluation. We go to profile. 90 degrees, we will obtain both eyes. I'm turning around. Both eyes, profile, mid-sagittal, coronal evaluation. Can we go from the posterior? If you go posteriorly, it's easy to identify the sylvius aqueduct here. Let's try again. The vermis and the sylvius aqueduct. Here, the vermis, the fourth ventricle, the primary fissure that should divide the vermis in 1/3 superior, 2/3 inferior, the aqueduct of sylvius. I don't know if you want me to show something or...
Anything special you are interested in? So you like him to show? Yes, please.
How do you measure the CSP?
How do you measure the CSP?
Well, it depends on the papers. Sometimes is on the middle, sometimes is the wider portion of CSP.
It's another question.
So the graphic from Xiaoyi is on the middle. The other one is the highest measurement.
Can you show optic nerves and chiasm?
We'll try.
Okay, thanks.
Oh, is there? It's easier to see on the third trimester, but it's between here and here. And here in sagittal evaluation and the optic nerve.
How do you measure the anterior ventricle? I mean the posterior horn.
The anterior horn?
No, the anterior. When you measure axially, you always measure the. How do you measure the ventricle which is near to the transducer?
We don't have really any magic to measure the proximal one, because if we try to measure like this, we will take an image that is not perpendicular, so we should not measure. If we tilt the probe to the shoulder of the baby like this, we'll be able to identify study the walls of the ventricle, but not to measure it. The best way is try to look if they are symmetrical, like this. These are the both posterior horns, and we can see that they are symmetric, so we can take the measurement of the distal one and assume that they should be symmetric.
Obrigado, Miguel. May you come forward together with Laurent?
Yes, I will.
Very good job. Because you are very systematic. The axial plane is in the middle. It's incredible. Could you just remind us how to look at the Sylvian fissure? Because some people look at the Sylvian fissure in the axial plane, yes. But you have to keep in mind that we should look at the Sylvian fissure at the level of the fornix, like that. Because I was told why you use the fornix. In fact, the fornix is a very small structure like that. And the CSP is large. So with the CSP, you can measure with an oblique plane. You still axial, but you change your plane. And doing that, you change the shape of the Sylvian fissure. So the CSP is it's very tiny because it's the end of the fornix column. So if you have this point, you are sure that you cannot modify the shape of the Sylvian fissure. Because if you look in the Congress, some people say, yes, I look at the Sylvian fissure in the axial plane. But they look, in fact, somewhere where there was cavum septum pellicidi. So I know that it's one more plane to know, but it's not very difficult. You just go below as you did. So this is important thing. And now there is plenty of way at looking at the Sylvian fissure. There is paper about doing this with transvaginal probe using coronal. I think this way of looking at that, it's a routine. You have to do this. So, and if you look at the guidelines of the ISUOG, there is a diagram showing, in fact, the things that you should look at. You have the Sylvian fissure, which is in the middle. So because it's in the middle, why you should have a look at it, even if it's not on the guidelines, because it's very, very simple. And I do this all time. I begin my scan looking at the Sylvan Fisher, as I did this morning for the live scan. I begin by that, looking at the CSP, look at the ventricle. So as you did. So thank you so much for your excellent live scan.